afternoon, everyone. First of all, I want to thank the organizing team for giving me this opportunity. So, I will be discussing about ABPA, that is allergic bronchopulmonary aspergillosis. So, I will start with some introduction to Aspergillus species and its virulence factor, various spectrum of pulmonary aspergillosis, epidemiology of ABPA, pathogenesis, clinical feature, various diagnostic criteria, and the treatment approach. Aspergillus is a ubiquitous saprophytic mold, and it has more than 200 species, and most common is Aspergillus fumigatus. It has very high sporulating capacity. Aspergillus conidia, the diameter of conidia is very small, that is 2 to 3 micrometer, and that they can easily penetrate the bronchiole and alveoli. The hyphae are acutely angled, and they can be stained with KOH, PAS or Gomori, methenamine, silver staining. These are the various virulence factors. So we have cell wall components like beta-glucan, serum galactomannan, and chitin. In cell wall, there are various proteolytic enzymes like proteases, elastase, and phospholipase. The fungus also has ability to form the biofilm. Melanin enhance the resistance to get phagocytosis, and thermotolerance enable the aspergillus to grow at the body temperature. Now, once the Aspergillus fumigatus conidia adhere to the respiratory epithelium, then it germinates into the hyphae, and hyphae will ultimately evoke the host response. The host response may be immediate response or early phase response or late phase response, and ultimately this immune response will recruit various inflammatory cells like mast cells, eosinophils, and monocytes, and they will lead to tissue injury, that is cytokine mediated, and airway inflammation, mucus plugging, bronchiectasis, and at later stage pulmonary fibrosis. This is the spectrum of various Aspergillus pulmonary disease, and the spectrum of Aspergillus disease depends upon the immunity of the host and the underlying lung condition. So if patient is immunocompetent and underlying lung is also normal, in that condition a patient usually do not develop the invasive aspergillosis, and there may be some hypersensitivity reaction. So patient may develop fungal sensitization, ABPA, or some hypersensitivity syndrome. If a patient is immunocompetent and the lung has some structural lung disease or some chronic inflammatory lung disease, patient may develop aspergilloma or chronic pulmonary aspergillosis or some semi-invasive form of aspergillus. If patient has severe immune deficiency, in that condition patient may develop invasive form of pulmonary aspergillosis. Now coming to epidemiology, first case report of ABPA was published in 1952 in UK by Hinson et al. If we talk about prevalence, the true prevalence is unknown because there is no community-based study, but there are hospital-based study, and it is found that around 1 to 2% of patients of asthma have ABPA. If we talk about ABPA prevalence at referral center, then the prevalence is 13% in asthma patient at referral center, and it is 2 to 9% in cystic fibrosis patient. So if we consider the 2% of ABPA prevalence worldwide, the global burden of ABPA is around 5 million. And in India it is 1.4 million, considering the fact that in India there is a high prevalence of ABPA in asthma patient as compared to the Western counterpart. Now, almost 30% of patients of ABPA may be misdiagnosed as tuberculosis or other chronic inflammatory disease, and there may be delay in diagnosis also. This is the study that was published in 2020 by Agarwal et al., and they have shown the range of Aspergillus sensitivity around 5.5 to 35% and prevalence of ABPA in asthma patient with a range of 2.5 to 22%. So as high as 22% of patients may have ABPA in asthma. Now coming to clinical feature, as most of the patients of ABPA have underlying asthma, so patient may present as uncontrolled asthma. Patient may have symptoms like breathlessness, cough, wheezing, hemoptysis if there is central bronchiectasis, expectoration of brownish black mucus plugs can also be seen. On examination, patient may have signs of airflow obstruction, clubbing, signs of pulmonary hypertension, poor pulmonary bronchi and coarse tracheitis. These are the various diagnostic modalities. So we have various serological tests like skin prick test, IgE specific to Aspergillus, total IgE, serum precipitin or IgG specific to Aspergillus, eosinophilia, etc. And in imaging, the gold standard is HRCT chest. If we talk about the most sensitive test, most sensitive screening tool, then IgE specific to Aspergillus is the most sensitive test, and this is the study published from PGI. They have shown the diagnostic performance of various tests, and they have shown that if we take a cutoff value of more than 0.35 of IgE specific to Aspergillus, the sensitivity is almost 100%. Now, serum total IgE is the one of the important essential criteria to diagnose ABPA, and usually we take cutoff value of more than 1000. That was suggested by the latest ISAM group. If we take the lower cutoff, that is suggested by Patterson et al., the specificity of diagnosing ABPA will decrease. So we usually take the cutoff value more than 1000. And another important feature of serum total IgE is that it is used for monitoring the response. Coming to the serum precipitin or specific IgG against Aspergillus. So serum precipitin is the surrogate marker for specific IgG, and the sensitivity is very low. It is 27% as compared to IgG specific. So if we take the cutoff value of 27 milligram per liter of specific IgG, then sensitivity is 89% and specificity is 100%. So it is a very good Riolin test. Now coming to various HRCT finding. So most common finding is central bronchiectasis. Another finding may be the mucoid plugging with bronchoceal, consolidation or fleeting infiltrates, central lobular nodule between bud appearance, bronchial wall thickening, area of atelectasis, etc. Now coming to uncommon finding. So high attenuated mucus, that is HAM. HAM is the most specific finding of HRCT. There may be some other uncommon feature like pleural involvement or some randomly scattered nodular opacities. This is the axial cut of CT scan of one of our patients, and you can clearly see that there is a bilateral central bronchiectasis. This is another patient with bilateral bronchiectasis. In this CT in mediastinal window, you can see that there is high attenuated mucus inside the bronchiole. And here you can see the pleuroparenchymal fibrosis along with bilateral bronchiectasis. So these are the various imaging features. Now coming to other testing, so sputum examination is not very important for ABPA. Though we can do sputum examination if we have some other differential like tuberculosis or other invasive form of fungal infection. PFT is done to know the overall lung function. Galactomannan is very important test for invasive aspergillus, but it is not a good investigation for ABPA. This is the evolution of various diagnostic approach. As I earlier mentioned, that the first case report was published in 1952. First diagnostic criteria was proposed by Rosenberg in 1977. In 1999, these criteria was updated by Greenberger, and in 2013, AIIMS group proposed the new criteria, and that these criteria were also updated in 2016. These are the Rosenberg criteria. There are major criteria and minor criteria. So to diagnose ABPA, 6 out of 8 major criteria must be present. So these are asthma, transient pulmonary infiltrate, immediate cutaneous reactivity, elevated total serum IgE, precipitating antibody against aspergillus, peripheral blood eosinophilia, elevated IgE and IgG specific to aspergillus, and central bronchiectasis. These are the minimal essential criteria given by Greenberger, and these are the latest criteria. So on the right side you can see the updated 2016 latest criteria given by the AIIMS group, and it has 3 domains. One is predisposing condition, another is essential criteria, and last is additional criteria. So in predisposing condition, there may be bronchial asthma, cystic fibrosis, COPD or post-TB fibrocavitary disease. So out of these predisposing condition, some of these should be present. Next is essential criteria. So in essential criteria, there are 2 immunological tests that must be present. So serum IgE specific to aspergillus more than 0.35, and increase in serum total IgE more than 1000. So these 2 tests should be present, and the additional criteria have 3 points. Serum IgG specific to aspergillus more than 27, thoracic imaging consistent with ABPA, and peripheral blood eosinophilia more than 500. Now this is radiological classification, and the latest classification is given by AIIMS group. So they have classified into 4 groups: ABPA-S, ABPA-B, ABPA-HAM, and ABPA-CPF. So if there is no radiological abnormality, so in that case we classify as ABPA-S, that is serological ABPA. If there is bronchiectasis, then we classify as ABPA-B. If along with bronchiectasis there is high attenuated mucus, then it is classified as ABPA-HAM. And if there is chronic pleuropulmonary fibrosis along with bronchiectasis, then it is classified as ABPA chronic, ABPA-CPF. Now, once we diagnose the ABPA patient, we have to stage for further management. So this is the latest staging given by AIIMS group, and they have staged into 6 groups. Step 0 is if patient is asymptomatic. So asymptomatic stage is stage 0. If patient have uncontrolled asthma or acute symptoms, then this is stage 1 or stage of acute symptoms, that can be further divided into stage 1A and stage 1B on the basis of mucoid impaction. If patient have clinical or radiological response along with decrease in more than 25% of IG, total IgE, then it is classified as stage of response. If there is clinical or radiological worsening after starting of treatment and there is increase in more than 50% of IgE, then it is classified as stage of exacerbation. If there is sustained clinico-radiological improvement for more than 6 months, then it is staged as stage of remission, stage 4. And if patient has treatment-dependent ABPA or have more than 2 relapse within 6 months of stopping treatment, then it is treatment-dependent treatment-dependent ABPA. And if there is patient have certain complication like core pulmonary chronic type 2 respiratory failure or extensive bronchiectasis, so these patient is classified under advanced ABPA. Now coming to treatment. So goal of treatment is to control asthma, to control the acute stage of ABPA, to control and treatment of exacerbation, to mitigate the progression of bronchiectasis. These are the various drug targets. The most important drug is oral glucocorticoid. We can also give some antifungal treatment like itraconazole, voriconazole or posaconazole, and we have biological also that can be given if steroid patient is symptomatic even on steroid and antifungal therapy. So in corticosteroid we have 2 regimens, regimen 1 and regimen 2. Regimen 1 is milder dose and with lower duration, while regimen 2 is given at higher dose. So in regimen 1 we give prednisolone 0.5 mg per kg per day for 1 to 2 weeks, then on alternate day for 6 to 8 weeks, and then we can taper 5 to 10 mg every 2 weeks and discontinue. And we should do the repeat chest X-ray and serum IgE after 6 to 8 weeks of therapy. This is regimen 2. So in regimen 2 we give prednisolone 0.75 mg per kg per day for 6 weeks, then 0.5 mg per kg for next 6 weeks, and then we can taper down 5 mg per 6 weeks and discontinue after 6 to 12 months. And we should also do serum IgE level every 6 to 8 weeks to see the clinical response. Now this is the study that published in ERZ 2016, and they have compared the 2 regimens, and they have shown that the exacerbation after 1 year and the glucocorticoid dependence was almost similar. There was no statistically significant difference, but there was a higher side effect profile if we use the regimen 2. So they concluded that medium dose oral glucocorticoid are as effective and safer than high dose treatment of high dose steroid. Now coming to antifungal therapy. So antifungal therapy are reserved for patients who are not willing to take steroid, or there is recurrent ABPA, or patient is steroid dependent as ABPA. Common agents are itraconazole, voriconazole and posaconazole. Itraconazole is the cheaper option, and voriconazole and posaconazole is the safer option. We give itraconazole with a dose of 200 mg twice a day for 16 weeks, then we can decrease the dose to 200 mg once a day for 16 weeks. Indication we have already discussed, and we should also monitor for various adverse effects and clinical response. And if patient does not have significant clinical response, then we should also do the serum level of serum drug level of itraconazole. This is another study that compared the itraconazole versus prednisolone. This was published in Chest 2018, and they have reported that the composite response was 100% with prednisolone as compared to 88% in itraconazole. And this is another study in which prednisolone was compared with combination therapy, that is prednisolone with itraconazole. And the primary outcome and secondary outcome was almost similar, but the side effect profile was higher in the combination group. So the current standard of treatment is oral glucocorticoid therapy as compared to antifungal therapy. And now coming to other treatment modalities, so we have nebulized amphotericin B, inhaled corticosteroid, and various newer modalities. So nebulized amphotericin B can be given as a maintenance therapy, but the good quality studies are not there. Although the time to first exacerbation, there are few small RCTs, and they have shown that the time to first exacerbation or number of exacerbation are lower as compared to if we use placebo. Inhaled corticosteroid, as most of the ABPA patients have underlying asthma, so we have role of inhaled corticosteroid, but in ABPA there is no role of ICS. And newer modalities like omalizumab, mepolizumab, and benralizumab can be given if patient is symptomatic, even on steroid with antifungal therapy. I am just running through these slides. So now coming to adjunct therapy. So we can use nebulized hypertonic saline and mucolytics if for better bronchial toileting. If patient have collapse of the lung with mucus plugging, bronchoscopy can be used. Pneumococcal and influenza vaccination are also very important, because the reason behind most of the exacerbation is because of some bacterial infection or some viral infection. Environmental control to decrease the ongoing exposure to aspergillus is also very important. And last resort is the lung transplantation in the last stage of ABPA. These are the various complications of ABPA. So patient may have recurrent asthma, exacerbation, bronchiectasis, pulmonary fibrosis, respiratory failure, PH, poor pulmonary due to prolonged or chronic hypoxia. Patient may have acute invasive pulmonary aspergillosis, aspergilloma, chronic pulmonary aspergillosis, and recurrent infection. So the take-home message is ABPA primarily affect patient with asthma or cystic fibrosis. Up to 22% of asthma patients could have ABPA. ABPA patient initially present as uncontrolled asthma despite optimal treatment. Pathogenesis is mainly due to type 1 and type 3 hypersensitivity reactions. And IgE specific to aspergillus is the key screening tool. And ISAM criteria are the current standard for diagnosis and staging. And first line treatment is oral glucocorticoid, and antifungal agents are reserved for if there is recurrent ABPA exacerbation or steroid dependent ABPA. Thank you so much.